Hello and welcome to a special edition of the Long COVID Advocacy podcast. And I say special because today's guest is Professor David Putrino, a neuroscientist and rehabilitation specialist who has become a prominent clinical and research voice in long COVID research. He's a professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai, and he's the Nash Family Director of the Cohen Center for Recovery from Complex Chronic Illnesses, often known as CORE, which is a centre dedicated to the researching and treating infection-associated chronic conditions. Since the start of the pandemic, Professor Putrino and his team have worked with many patients experiencing long COVID and infection-associated chronic conditions. He has also been involved in education around CME-accredited long COVID, ME, and chronic Lyme disease education, and he's part of the long COVID open medical education program at Polybio. So without further ado, let me let in David. Welcome. Wonderful to have you here. We know that our audience are discerning and knowledgeable, and we've got the perfect guest today to give us further insights into long COVID. It's a real pleasure to have you here.
Oh, it's great to be here. Thank you.
I was saying in our little warm-up that our questions are fairly intense and detailed and get right to the point of those issues people really want to hear about. So I think this is as close to a warm-up question as I've got for you today. There are so few specialists in the field of post-acute viral illness, one of the newer terms for conditions like ME and long COVID. So what drew you to this field when so few had cleared a path before you?
Well, from my perspective, I guess I have a hard time walking away from areas of clear need, and so from my perspective, it was really just that we had thousands of patients attending our clinic at Mount Sinai because after the pandemic. After the initial phases of the pandemic, I should say, it's very much still an ongoing pandemic. But after 2020, we just had, with Mount Sinai and New York being the epicenter of the epicenter, we just had so many people attending the clinic and saying, "What are you going to do?" And all around the country, we started to see this sort of progressive retraction of services toward folks with long COVID, toward folks who had all sorts of post-acute sequelae. And we just didn't want to be one more of those centers that was, we didn't want to sort of stick our head in the sand and say, well, the problem's over because the country is opening back up and the world is returning back to normal, or the new normal, or whatever, we want to call this phase that we're currently in. But the point was that there were very clearly people who were still extraordinarily sick. The data that we have and the data that was recently just published by Recover NIH shows us that the rate of new long COVID diagnoses has not slowed down since 2020. So it's not just a problem for people who are already sick. It is a problem for all of us moving into the future.
Yeah, it's not going away.
And so it was just very clear that it was clear to us and to our ethics and to, the sorts of people that I'm really fortunate to work with who don't turn away from a challenge, that this was something that just had to continue so that people could have options. And crucially, in the work that we do, something that had to continue in a way that's covered by insurance, as opposed to, hey, let's create, a self-pay clinic that's very, very expensive and, boutique-like and, because surely we could do that, but that's not solving a problem. That's, that's just, it's solving a problem for a very small percentage of people.
Yeah. And it could potentially, give a certain impression about, like a fashionable illness, as it were, which we've had problems like that in the past.
Yeah, absolutely. We all know the tropes.
Brilliant. So, is it fair to say that that medical education and attitudes have consistently failed patients with ME and long COVID. And to the extent that that's the case, what do you think are the roots of that failure? What's gone wrong in how medicine conceptualizes complex chronic illness?
Yeah, I do think it is fair to say that medical education has so far failed people with long COVID and ME and other infection-associated chronic conditions and illnesses, things like chronic tick and vector-borne illness. And I think that the sort of the structural roots of the failure really focus on the fact that healthcare doesn't do well with complexity. We don't like things that we don't understand. We tend to, if we take the words of Susan Sontag, we tend to metaphorize illnesses we don't understand. So we tend to create stories around illnesses we don't understand. Sontag wrote about being told that she got, being told by a doctor that she got cancer because of her cancer personality. That was in the 80s when talking about a cancer personality was a thing that people did, and we've thankfully moved beyond that in oncology. But I think that in invisible illnesses and illnesses that are poorly characterized and poorly understood by mainstream clinical practice, we're still in this phase of metaphorizing. It's easy. It's, dare I say, lazy, but lazy is easy to sort of say, well, I can't really see why this person is sick. All the tests are coming back normal. It's probably in their head, And I think if we look at some of the education around ME/CFS over the decades, and we look at some leading medical schools, someone showed me an image that is, a slide in a presentation about ME/CFS that was taken from, Harvard University Medical School, where, the depiction of a person with MS, there is a cartoon and they're sitting in a waiting room and they're kind of sweating, and they've got a book under their arm, like a medical book, and they're frazzled, and and so the depiction there is, here is this hypervigilant, prone to anxiety, high health conscious individual who's sitting
with the temerity to try and learn something about their illness.
Exactly. And that, that really, when that's the way that you're teaching students, that creates stigma from the outset. That creates a mindset from the outset that when faced in the real world with a person who says, this is my diagnosis, it's long COVID or ME/CFS, immediately they're going to think back to that lesson and they're going to say, oh, well, I learned about this and this is probably psychosomatic, or this person's going to come at me with lots of medical jargon that I don't really understand. And so I do think, to that end, we have failed to date. I think, one thing I'll say that is hopeful is that as my team and myself go out and do medical education ourselves, what I'll say is, I don't think that anyone really wants to stigmatize patients. I don't think that people want to not understand what their patients are going through. If for the majority of cases, I don't think it's fair, just like it's not fair to characterize people with ME/CFS or long COVID in the way that I just described in, some of these textbooks. It's not fair to characterize the majority of clinical providers as heartless, unfeeling individuals who don't want to help. I think that the truth in the middle is we have a lot of folks who just don't get a lot of targeted education, get frazzled, make bad decisions because of the lack of education. And what has been a learning of mine as I've been going around the the country, in the United States, and in some cases around the world, teaching, is that people meet me with curiosity and actually feel really relieved to be given a roadmap of, well, if someone walks in and says they have long COVID, here's the first thing you should do, and then here's 10 more things you can do, and then here's a bunch of medications you can try, and so giving people a roadmap immediately releases a lot of this anxiety, because I think a lot of this anxiety from providers comes from like, well, I don't know what to do when this person walks in the room. I don't even know how to identify what they have. And we've even had surveys where we ask providers before the education, are you convinced that a diagnosis like long COVID is real? And in one survey of 200 providers, 30% said no. And then after an hour and a half of education, 0% said no.
Wow. Wow.
All of them said, oh, I actually, I actually believe that like long COVID is legitimate. And so that was just an hour and a half showing very well cited literature, educating people. So I think people are open to it. They just haven't done that before.
What a precious hour and a half.
Yeah.
With, when you think about its potential impact on goodness knows how many thousands of patients, or, that's the power of education models, isn't it?
Exactly.
And what really struck me about what you're saying is about that response to complexity. When we think of what, broadly speaking, Western modern medicine does best, it loves acute trauma and localized single point conditions, doesn't it? From a broken leg to a located cancer, and it's on, and you can save that person, and you know what to do. But when you're talking about multifaceted, complex presenting, then it suddenly becomes the flowchart model doesn't work. And it's interesting, we'll explore a bit more what you mean by like the roadmap instead, which is a bit more complex than do A or B, isn't it?
Exactly. And you're so right, even when we talk about the systemic issues, even just when you think about the way that we're invited to speak at conferences, and I'll be told, hey, can you keynote at this conference? You seem to know a lot about long COVID. Can you keynote at this conference? 25 minutes to talk about how to treat long COVID, and I think that that's because in less complex illnesses, we have created such an algorithm that you can, in a simple, well-characterized pathobiological state, you can say, this is what's going on. This is the pathobiology that's well characterized. These are the drugs that hit the targets. This is best in class. And here are some new cool drugs that are in the pipeline that should be done in 5 years.
Yeah.
Good, presentation over. Whereas we're not there with complex chronic illness. And so even the challenge of being told, present something in 25 minutes, if you're not careful, you can do more harm than good to providers, because suddenly they're like, well, this doesn't seem like a well thought out model for a disease or an illness, so the system sets you up to fail sometimes if you're not careful. And I often preface a lot of my talks when they're very short with like, listen, we're not going to get through everything, so I'm going to give you some real basics to think about what we're doing.
Yeah, and you can just, in that time, you can just about open up people to what they don't yet know they know, what they don't know that they don't know.
Yeah.
Yeah, absolutely. Thanks for that. And so, I mean, we've touched on this, but are there any sort of particular textbooks or training models or guidelines that you think have like disproportionately shaped clinician attitudes towards ME and long COVID?
I think honestly, from my perspective, what I hear the most from providers is there are so many books now that are written from the patient's perspective that, providers are always telling me like, this was the thing that turned it around for me, like reading about this person's story or reading, a couple of them that pop into my mind are, Megan O'Rourke wrote The Invisible Kingdom about chronic Lyme disease. It's such an incredible way to think about chronic illness, complex chronic illness. She writes it from such an empathetic standpoint that you can almost feel everything that she's going through. And providers have told me that that really gives insight into like, this is what it feels like. Books like Brain on Fire, but these books that give very visceral descriptions, because I think that that's what's needed for providers. I think what's needed is like, that you can't trust the textbooks. So let's show you, like with our most eloquent people who are representative of the illness, let's show you what it really feels like to be sick with these things.
Does that feel like it's a emerging pathway in medical education that, these are, with respect to certain complex conditions, you just need to start by listening to these people? Is that something that people are acknowledging as valid? And
100%. I can't speak for every medical school in the world, but I can speak for the medical school that I work at, and increasingly patient experience is being built into the medical education curriculum. Increasingly, and including in the classes and the courses that I teach, like the last class of the semester will be meeting with patients who have the condition and conversing and talking and asking the questions that you want to ask. And I think that for extremely stigmatized or for poorly understood illnesses, it's even more important to do that, because I think that nothing removes doubt from your mind that someone is desperately ill than seeing that person desperately ill and having the lived experience of seeing someone in some of their toughest and most vulnerable moments. It's undeniable when you see someone with severe ME or when you see someone with severe long COVID, severe Lyme disease.
I hope so. I'm going to jump script a little bit there just to reflect on that, because perhaps there's a different, that undeniability, as it were, because it may well be that in the case of the medical education context, where you are there to learn, they are there to learn about conditions, but in the actual clinical setting where you're dealing people with acute conditions and presenting in very severe ways, we know from, and people watching this many of them will know from personal experience how unsympathetically they can be received, and how violently they can be disbelieved. So is there a disjunct, between those settings then? And does that make it even more important that the medical settings prepare them for those clinical ones?
Yeah, I definitely think, I think in the educational space, and learning patient stories, seeing, all of these things that I was talking about, getting a feeling of the lived experience. How that's different from the clinical experience is, in a clinical setting, a clinician is stressed. They're probably already 50 minutes late. They're trying to get through a session. They're trying to get through a session that should take 2 hours in 20 minutes. You've got a patient who's stressed because they're, first of all, extremely concerned that they're not going to be believed. Second, they've probably got a laundry list of things that, they're like, okay, this is the last time I'm going to see this person for 3 months. I've got a list of priorities that I want to achieve in this meeting. And, acrimony ensues, unless you're a very special kind of provider, or a provider who's been appropriately trained to sort of de-escalate, everyone take a breath, and go through, bit by bit, what can we do for you that is most meaningful, so that you have some hope and some stuff to do, and and some new things to try over the next 3 months. Because I think what I've heard most from patients is that what everyone dreads is waiting 3 months for an appointment, feeling like garbage, going into that appointment, kind of just being disbelieved and gaslit, and walking out with no new insight, possibly having paid a lot of money for the appointment, possibly not, but either way, it's just not a great feeling.
Yeah, it's precious either way. Yeah.
And anything that you can do to prevent that. I hope that explains, but to my point, like creating a safe, I hate to say it, but creating a safe space for people to actually experience, have a lived experience where it's like, it's not that the person with the condition is asking anything of you, other than to listen and other than to believe. You're not being expected to help, or you're just being asked, I just want you to see what the truth is.
My specialism is in school education, and very similar things apply compared to when you're there controlling the classroom, compared to when you're talking about the situation with others and being given the chance to reflect. And that, I think, what's very similar also is that idea of control panic. Clinician or practitioner panic. They need to feel that they're in control of the situation, that they're expected to be in control of the situation and know what to do. And anything that threatens that through complexity or through difficulty in communication, it all threatens that, and then it can lead to knee-jerk responses.
Yeah.
Can you tell me a little bit more about medically unexplained symptoms, this idea, and their role in shaping doctors' attitudes towards long COVID and ME patients? Do you think these sort of frameworks have unintentionally entrenched perhaps psychosomatic assumptions in the way that are now difficult to unwind?
Yeah. I think, what I can actually do is I can share a personal story on this front, which is that, I think that, unfortunately, what can happen is, based on the way that certain terminology emerges or is coined, it can sort of dictate the stigma that it holds, even if the terminology itself doesn't necessarily seem objectively offensive. So when I see the term medically unexplained symptoms, that's fair enough.
It should be a neutral term, right? It just means we haven't got the answer yet. Yeah.
And right now, they're as yet medically unexplained. Like I can understand that term, right? And interestingly, a cousin of medically unexplained symptoms is medically unexplained physical symptoms, MUPS. Which is also a term that was thrown around a lot. And when I was first entering this space, when my only experience was with long COVID, and I'd only been sort of studying it for a couple months, I heard the phrase medically unexplained physical symptoms, and I was like, oh, that is actually, a good word for, a good phrase for it. And I used it as part of a framework of, like, people have these medically unexplained physical symptoms, but if we dig into the drivers, we can find out that they are actually explainable, which is, now that I know the context, is quite funny. And it was actually a patient who reached out to me afterwards and very kindly said, hey, I really loved your presentation, but did you know that, like, that's a really problematic term that you used? And I was like, oh my God, no, I'm a newbie in the space. Thank you for letting me know. Let me educate myself. And of course, I see that medically unexplained symptoms sort of just emerge from, hysteria and somatization and psychosomatic. And so all of this is to say that, unfortunately, I think we need to leave, even if the phrase is innocuous at face value, it needs to be left behind because, because what we see in all language. So if we move away from medical language, this can be, racially charged language. This can be just generally swear words. We always learn that groups that are stigmatized and groups that are minoritized historically we tend to have to keep changing terminology to protect them because stigmatization has been happening and certain words are used as dog whistles or as ways of continuing to stigmatize these folks. And what we need to do collectively is figure out, okay, well, when people say that is code for that. So let's move away from saying that. Let's come up with new phrases. And I think that's where we are with MUPS and MUS, is it has to go because, it comes from a time and a place when people were being told that they needed the rest cure or the ECT, and that's just not acceptable. And it's not where we want to be scientifically.
Yeah, and I guess you can relate it back to that kind of flowchart model, if you like, in the sense that if you start from a place where you believe that effectively the medical system has structures that work for patients in a sort of flowchart way, then anyone who doesn't fit that, by default, the problem is with them. So rather than the fault is on us for not yet understanding it, the fault is theirs for not fitting into the system, thereby implying that there's probably nothing wrong with them in the sense that we would normally imagine. Yeah. Thank you. So, I mean, in the UK, the ME delivery plan here promised sort of improvements in medical education. But what materialized were sort of 3 voluntary e-learning modules, and freedom of information data from Lucy B showed very low uptake of these. So why do we repeatedly see these sort of minimal optional interventions rather than structural curriculum reform?
Yeah, I think largely we run into these problems because we run into these problems because change is hard. Systemic change is difficult. And so one of the things that I always think about is even if we move away from long COVID, infection-associated chronic conditions and illnesses, and we just think about working in a hospital, trying to change the way providers do one thing. Frequently, it just, it takes years, and you get resistance from every angle. All of this structural bureaucracy, depending on you doing things one way, and no one ever thinking for once about the patient. Everyone just thinking about like, no, this is the way we've always done things. So why would we change that? And so, I think why the reason we repeatedly see these problems is because there's not enough people making noise at multiple levels, because this is a thing where you need to make it everybody's problem to drive the structural change. And I do think that, and maybe I'm just biased because of what my institution is doing, but I do think that we are starting to see structural change. I do think we're starting to see institutional change because we are engaging in infection-associated chronic conditions and illnesses and curriculum at our medical school. First-year medical students are getting taught it. They're sitting in lectures that I'm giving, God help them. And we also have representatives at HHS, from the last administration and from this administration, HHS being the Department of Health and Human Services in the US, saying long COVID is a problem, chronic Lyme disease is a problem, ME/CFS is a problem. And, and that is the last two administrations that have been saying that. And I think that that was not something that was being said previous. Okay. So I call that progress.
And you haven't met any major roadblocks yet under the present administration with respect to
No, in fact, thankfully under the present administration, I was invited to DC to speak about long COVID. The manual that we created that talked about our clinic's approach to treating long COVID is now actually prominent on the HHS website as a downloadable resource that anyone in the country can download for free. It has been encouraging to see, that this is a bipartisan issue. I do think to some extent, my own observations for what that is worth on this topic is that COVID has touched everyone. Yeah. COVID doesn't care if you're a Republican or a Democrat or, left or right on the political spectrum or right in the center. It's touching everybody. Everybody has a story about long COVID, even if they don't know that it's long COVID. Everyone has a story of just not being the same after, a viral hit. And although post-acute infection syndromes, infection-associated chronic conditions existed beforehand, it does seem that COVID is that much more effective at causing them, according to the existing data that we have. And so I think that, there is a much larger sort of groundswell of people saying, hey, we need some help here, and we don't really care who gives it.
Okay, that's good. I mean, I guess that's almost hopeful.
It's almost hopeful.
it's a message, but you're almost the critical mass almost of people, but so often and until very recently at least, and perhaps still now, show me an advocate for people with long COVID or ME, and I'll show you someone who's either had it or who's found someone in their family has had it, and whether it be a clinician or a politician, or it's always been through that close association, where for other more well-known conditions or more recognized like cancer, people's empathy has been able to spark and jump much further, hasn't it? But with these conditions, it's nearly always found closer to home.
Yeah, no, absolutely.
So, I mean, partly then from your experience now, what does it take? What would it take, or what does it take to embed ME and long COVID knowledge of those conditions properly into undergraduate and postgraduate medical training, not as optional add-ons, but as core competencies? And, if you had the authority to redesign the curriculum in other institutions, what are the sort of top three changes or top three things that you would bring about?
Yeah, I think I can speak to my personal experience on adding infection-associated chronic conditions and illnesses to our medical curriculum, and you do need to be a little bit patient, it does start off as an optional add-on. Our medical school curriculum gets changed every 4 years or so, right? They redesign it, they rethink it, they reimagine it. And so 4 years ago, I was saying it's time for us to add in long COVID and other infection-associated chronic conditions. And I was kind of laughed at, they were like, ha, 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 you're so naive. Yes, we're about to change the medical curriculum. It is true. You heard right that we're about to update it, but we've been planning those updates for 4 years, So they said, what we can do is we can give you like this course, and and it's an optional and blah blah blah, and so I taught that course for the 4 years and 3 years, and it consistently had high feedback, and it consistently had like lots of people signing on to it, and people just enjoyed actually, the younger generation of trainees enjoy the complexity. They like the challenge of like a complex problem, and of course, like everyone knows someone with long COVID, so they're like, I want to learn more about this thing. And so, from there, I was told, okay, we're going to add you to the MD PhD program, and you're going to give a structured lecture on infection-associated chronic conditions and illnesses to our MD PhD program and our PhD program. So that gets built in because the school decided it's a good idea, given that these are illnesses that affect so many people. We should expose PhD students to it if they want to study it for their PhD, and then as we've started to develop the medical school curriculum, now I'm starting to finally have conversations with the curriculum builders about the first year solid core curriculum, and getting one lecture on infection-associated chronic conditions and illnesses. So, so it is this very sort of stepwise process where you need to show that it's, engaging content, show that the students seem to genuinely want to hear about it. And
that's interesting in itself, isn't it?
It's
almost like a consumer model. Oh, will they enjoy it? Will they appreciate it? Will they give it 5 stars? And it's like, is that the process here?
Well, it's an interesting, like what I frequently get told is I push on these, pull on these threads and push these buttons is like, listen, there's a lot of competition for what they get bombarded with so much content.
Of course.
There's a lot of competition for what should be added. So we need to be sort of democratic about like, what do people most want to hear about? And which is an interesting way to think about how but then when I sort of like bristle at that and think, I'm like, well, yeah, how else do you do it? Do you do it as a public burden statistic viewpoint, in which case the rare diseases will say, hey, we're missing out,
how interesting. How interesting. I guess what you're saying is, if you're going to have that model, you also need public awareness campaigns and everything, so to increase its salience with those trainees in the first place, so that they have something to tap it into, connect it with, and make it seem like it speaks to relevant experience in their life and like a problem that they want to be able to address. You know what? Going off script again a little bit, I'm just struck by the parallels. My work, I'm not going to talk about it much, but is on climate change and sustainability education. And of course, the educational, the school curriculum is perhaps even more of a behemoth still in terms of any significant change. Has it changed much in 100 years? Barely. But even at this stage, knowing all that we know for decades, still we just have reviews coming in say, oh yeah, maybe a bit we can mention climate change a bit more in geography and science, maybe once or twice. And it's like but this challenges our whole paradigm for how we do educate. It's not just a little add-on. It's a problem. It's something that we don't yet fully understand, to the extent we do, we don't know how to fix it yet. And so it's a different paradigm for learning and acting. And these illnesses are something similar too, right? An education around them is like a space of not yet fully knowing, rather than just a handing down of information in a nice package ready for them to implement. So it demands and like you say, that can be exciting, but it's very different from just even the way it's presented, perhaps, from the way other conditions are.
No, absolutely. And to your parallel, it can be exciting and it can be extraordinarily daunting. To the point of existential dread. Climate change is something that if you read too much about it, you become full of dread. You're like, oh my God, what are my kids going to do? And what are whatever. When you start really digging into these infection-associated chronic conditions and illnesses, you start to think, oh my God, I need to stay healthy. I can't get sick. I need to, every infection matters. Every immune hit that I take matters. And it's a really, like, a lot of people come out of some of my lectures, if I give the lecture in a bad mood, terrified, and I think it's because it is such a huge, all-encompassing topic. I firmly believe that it's in a whole population that seems to suddenly be obsessed with longevity. It's a factor that no one is building into their longevity models. None of the sort of like so-called longevity gurus are building into their longevity models. It's just like the simplest thing ever, which is, exposure to viruses, exposure to pathogens. How are you limiting your access? It's something that, again, to draw a parallel to climate change, if we want to protect our children, what should we be doing? We should be doing testing. We should be doing far UVC. We should be doing good ventilation. We should be doing vaccination or vaccination alternatives such as monoclonals for post-exposure prophylaxis. And we should be doing masking if we're in high-risk environments. And I say if we're in high-risk environments for masking only because if you do all of those other things, you actually wouldn't need masking. If you actually said, hey, test your kid every morning, and if they show up sick with strep, RSV, CMV, etc., don't send them to school. If you did all of those things, masking, which everyone has fixated on and pitched battle stations on, either anti or pro, would actually be the least important mitigation if all of the other ones were in place.
And you wouldn't even need to do the other ones perfectly either. Each one would massively reduce, And even then, the masks were rubbish. Even then, they couldn't even get us to wear the right ones. But
No, I know. Yeah, and crazy. When I see a lot of the vitriol around masking, I actually, I often think about it. I often think about climate change. It's funny you brought up climate change, because I often think about like how when recycling came into vogue, we were like picking on people who wouldn't recycle, but the oil companies are getting like subsidies from the government. And it's like, if the government had, rather than saying, hey, it's on you, Jimmy, like put that plastic bottle in the right bin, and had actually said, you know what, we're going to invest like $2 billion into solar, and we're going to tax oil companies, like the problem would be much, much better than it currently is. And so I sometimes think about that. It's like, if you see someone in an unmasked space, unmasked in a space, rather than getting angry at them, get angry at the fact that we had a 2-year period where the government could have implemented, all governments, could have implemented incredible risk mitigation strategies for clean air that would have several generations thanking us for like good health. And we just failed.
It stuns me that people can't see the links between, the end of the 19th century drive to clean up urban water and, the drive now to clean air, that people, you just can't see the air, can you? And it's just, people can't connect with it in the same way, but, the logic is flawless. It's deeply frustrating. Anyway, I'm going to get back on script before I go. Okay. Otherwise, there's a whole joint book in there somewhere about the parallels between climate change and post-acute viral illness, but we'll leave it for another time. Patients often have a hard time trying to inform clinicians about their illness. What advice would you give to them about doing that? What sort of resources might be able to you suggest that they look at or take, or indeed what sort of resources might those clinicians engage with to reduce the stress of that, or the friction of that encounter?
Yeah, it's a great question, and I'm always loath to put more work on patients, but sometimes this is the just the reality of the world. But I will start with clinicians because the reason we released our manual was like, again, it wasn't like this is the way to do things. It was just this is the way we do things, and if you were curious, now you can do it this way as well. And one of the things that we'll be updating in the forthcoming version of the manual, which should be out in the next couple of months, is we've added health coaches into the workflow, and what the health coaches do is they meet with patients, and we've created these little like templates for patients for their appointments, and it's sort of very structured in a way of, what are the things that you most want to bring up? What are some of the pieces of evidence that go along with the, with the things that you want to bring up? So like if someone, for instance, wants to try a certain drug protocol, what is the evidence that makes you want to try that drug protocol? So like pop that into the plan. And so rather than saying here's a specific resource or here's a specific thing, because there's so much variation in what patients experience day to day, really what we try to do is personalize that planning of the appointment. And so my first advice to clinicians is having health coaches available is invaluable to patients. In the US, we're able to get it covered by insurance much of the time. It's not a whole lot of time and it's not a whole lot of money, but it's really, really invaluable and helpful to patients. And so if clinics and clinicians can achieve that is something that is really not just helpful for the patient, but helpful for the clinician, because then it gives an appointment that could have otherwise had no direction, a lot of direction. And it leaves everyone just a little bit more satisfied that the appointment went well. And
there's a cultural shift there as well, isn't it? Mediated, as you say, by the health coach, of sort of co-agency, if you like, that is still missing in many contexts and settings. To take you back to that image you presented from the beginning of the hypochondriac patient with the medical book under their arm. I and we here know of many examples of patients trying to come informed and with structure to their appointments, and then meeting hostility as if they're trying to take control or put the doctor in their place, and again setting off that panic response. That hold on, but I'm in control. And so but it's a cultural change you're describing, and the idea of it being mediated in that way is a really interesting one.
Absolutely. And to your point, which I think is a really good one and well taken, I mean, I think we also need a lot of providers to check their ego, because yes, this is the new way of doing things. Co-agency is in, and bodily autonomy is in. We can't throw these concepts around, and say that we believe in them and then not show that we believe in them with our actions in a clinical setting. And what we need is providers who actually walk the talk when they say that, okay, I co-design my clinic and my approach with my patients, and it's a partnership, and patients as partners, we hear that one a lot. If you're going to say that, you got to do that as well.
David, there's a sort of, what you're saying is really hopeful, and it also provokes a sort of sadness or wistfulness in me when I think of another story in the UK press recently of another young woman at the brink of death with severe long COVID, with very severe long COVID, not being fed because she's been told that she should sit up and eat.
Yeah.
And that protocol doesn't allow them to feed her lying down. And there have been several cases like that. And the latest one, they managed to flee to another hospital with support where they were deigned to be fed.
Yeah.
But there is a whole other side to this, isn't there, where it breaks down into an authoritarian and sometimes deadly relationship, where all of those elements of misunderstanding and panic and control that we've talked about just flip the other way.
Yeah, you're 100% correct, and it's not my intention to go easy on those folks. There is some absolutely diabolical behavior that occurs in this space, and we've all seen it. Those of us who have worked in the space now, we've seen it. We do our part and sign petitions and write opinion pieces, and what I find the most tragic about this situation is progress is happening, and I do want to lead with the fact that progress is happening. There have never been more providers who are aware of these illnesses. I'm hearing about mast cell activation and antihistamine. There's never been this much good progress in the space, but we can't ignore the fact that there is still the tail end. These things always happen in a distribution, and there is still this tail end of absolutely unacceptably hazardous behavior to patients that has to be hunted down and struck out. It's when we hear about these things, in my opinion, we can't come down hard enough on the perpetrators of these human rights violations, because that's what they are, and they're happening out of sheer ignorance and unwillingness to adjust behavior with updated science, which is malpractice. So,
and that ego and people's power as well. People have positions of authority, don't they? And they have reputations built on holding certain positions, and in teaching other people certain things that come under threat from some of these conditions.
Yeah, absolutely. That is I think I said earlier, the majority of folks, who are presented with the education that I provide, typically you see them in the audience and they're nodding their heads and their eyes are wide and they're taking in the information and they're like, wow, but I will say there's also, I'd say, one every 3 talks, there's always someone in the back, arms folded, frown on their face.
Yeah.
And invariably this person will always approach me and they'll talk about, psychosomatic symptoms, and they will talk about, they'll talk about FND, and they will talk about cognitive behavioral therapy, and they'll talk about unhelpful illness beliefs, and they'll talk about their successful practice, always their successful practice. And as soon as I hear successful practice, I'm like, oh, so you're just here protecting your turf, the only reason you're arguing with me is because you don't want, clients taken away from you. Whereas the difference between me and you is, if I'm wrong, I want my patients to go elsewhere and get better. If they can't get help with me and at my center, I really want it. All I want is for them to go off and get help somewhere else. I would never stand up and say, even though you're helping someone, I think you're wrong, and it's it's all about me. So that's ego, that's greed, that's medicine for all the wrong reasons.
Yeah, and you can always ask, well, what's the graded quality of the evidence that you're relying on as you make that judgment?
Yeah.
Because that's what that research doesn't have, does it? You know, and that's what it's been. But I'm going to reconfigure my last couple of questions because I think partly answered them. But but what you're saying, you know, because what you're saying is you're giving us a postcard from a place where things are changing, and there's some really hopeful practice and really hopeful cultural change going on. You know, and I think things are very different in other countries and other places, perhaps in the US, but also in other countries too. And there's very varying practice from country to country, as you know, you have those different contexts. How is the work that you're doing and that colleagues are doing starting to spread out beyond your borders and reach out, you know, across the country and internationally through remote learning and that sort of thing? What are the prospects for that?
Yeah, you know, I think yes and no. We are definitely giving a lot of international presentations. We're definitely getting out there and, you know, and talking about things to colleagues internationally. I would say, you know, full disclosure, as you know, as an Australian who grew up with socialized medicine, that worked, in my opinion, very, very well. By the way, like I don't know, like a lot of these expats go, oh well, you know, terrible system. I was like, it worked for me.
A lot of it's funded well.
Yeah. And now I've worked in the US system, which has its bright spots and its dark spots. Yeah. You know, I think you get a bigger distribution of care quality in the US, but it's a bigger distribution. You know, both tails are longer. One of the things that I'll say, if I could wave a magic wand and change things in the NHS or in Australia or in many parts of Europe where there's sort of single payer systems and socialized medicine, I would say that the sort of right to try and the ability to easily prescribe off-label medications really needs to change, because I view that in my presentations, in the responses and questions that come to my presentations, that seems to be the most common thing, is like, oh, well, it's okay for you in the US, you can just prescribe things, and it's, you know, it's on you, you can do that. Evidently in the UK and in Australia, it's much, much harder to do something like that. And people can come for your license, and it's quite strict. So that would be one thing. And then the other thing is, excuse me, the other thing that I find a little bit, you know, troubling is, or problematic for care here, is that there is a little bit, the patient has a little bit less autonomy in socialized health environments about what they want to do. It is a lot more pathway driven than a system where you can actually say, you know what, I'm going to go and pay for it myself out of pocket, and come what may. So those are things that where we differ a lot between the countries, and it does, these two things seem to be a barrier to uptake of a lot of the strategies that we're finding useful,
right,
in the UK. And
so once those structural barriers are removed, then the messaging will get across more easily, you think? So at the moment, people might be hearing it and think, well, we couldn't do that. Yeah. Okay.
I mean, I don't know. I don't know. You know, I just have hearsay. But I mean, even some of the stuff that we talk about with antihistamines, you know, it's like, it's radical. You know, like just the idea that you can give people 2 or 3 different, you know, antihistamines and hope that they do well, is like, oh no, that's not even, you know, Pepcid isn't even over the counter. Like, we need, you know, prescriptions for famotidine, and we need to justify it. And I mean, Pepcid, our docs in the clinic, you know, like Pepcid is one of the you know, first tools they reach for. So it does. I'm not gonna say it doesn't cause,
Sure.
cause some issues.
But a greater degree of professional autonomy, you're suggesting, is needed to deal with some of these more complex conditions, perhaps.
Exactly.
Yeah.
Exactly.
Fantastic.
Yeah.
David, you've been really generous with your time, and I'm aware we've had a fair bit of it. I have, if you do have time and inclination, I've just got 3 or 4 questions from general public who, and they've emailed them in advance. I'll try and fit them into 10 minutes max, and feel free to give short answers as you wish, but I would really like to allow them to be heard if you wish. So a question here from Michael: how do we stop the conflation of fatigue and PEM, or post-exertional malaise, and how do we get that acceptance that PEM is a real phenomenon?
Yeah, education and research. A lot of the educational sessions that I take, I really break down the difference between fatigue, sleepiness, exercise intolerance, and PEM. Those 4 constructs, and I say these are how they're different. This is what it is, and these are ways that you can measure each one. Because I think that it is an educational failure. I facepalm myself at some of my early long COVID papers because I was just talking about fatigue. I didn't know what PEM was. It's a distinct construct. And then I think in terms of how do you show that it's a real physiological thing, we need more and more research on that. But I mean, in a fair world, in a just world, the work that Rob Wist has already published on the way that muscle fibers in people with PEM respond to submaximal exercise, the way that mitochondrial processes change in submaximal exercise, it very early switching over to anaerobic ATP production that cannot be explained by deconditioning. And his recent work, which is pre-printed but not published yet, is beautiful in that regard, where it shows truly deconditioned people who have been on bed rest for 3 months, as part of like NASA and space studies, not having the same metabolic responses to exercise as people with PEM and long COVID.
So important.
I'm really hopeful that the good work being done by folks like Rob is going to turn the tide on that, because already I think the evidence is undeniable. We just need to get people better understanding the evidence, because a lot of folks don't understand exercise physiology.
David, you're making me far more hopeful than I was expecting to be.
Oh, good.
A question from Elke: what do you think is the relationship between long COVID and ME?
So I think that long COVID and ME both hold their place in infection-associated chronic conditions and illnesses. In fact, I would even say, I like to say, and everyone hates when I say this, but I like to say infection and exposure associated chronic conditions and illnesses, because I want to make room for the fact that Canadian consensus criteria, which is what our clinic uses to diagnose ME/CFS, can be from a car accident, can be from a surgery, can be from,
other forms of trauma,
or stress response or immune response, and we think about it as these sort of recurrent immune challenges, these successive hits that can then kick you into this disease state. I do think it's important, even if you have a long COVID and an ME diagnosis, I think it's important to retain that long COVID diagnosis, because I personally believe that from the literature that both we've published and others have published, that the pathogen that infects you matters in a reasonable subset of people. And so knowing that you have long COVID, knowing that COVID was the index infection that triggered your illness, could be very important to your treatment.
We don't know its full significance for future understanding and treatment.
Exactly. And so that relationship, I think, is really important. I also think that we can learn more by studying everyone under one big tent. And I happen to be, we've all heard the sort of adage of there's lumpers and splitters. There's people that lump everything together and there's people that split. I happen to be a splitter. So what I want to do is I want to bring everyone under one tent. And then I want to say, well, how many groups can I split you into now that we're all under one tent? Now that fibromyalgia, ME/CFS, chronic Lyme disease, babesiosis, long COVID, you're all under one tent. Now let's start to, okay, you've got reactivated viruses, you've got persistent COVID, you've got POTS, let's figure it all out.
David, you're a philosopher at heart. You like making distinctions. I can see that. I know the feeling. I've got a question. Thank you so much for that. A question from Lindsay regarding dysautonomia and gut issues, especially for those who cannot absorb nutrients well enough, either through slow transit or not getting enough food in. Has any progress been made with those conditions or issues, and how do we halt the progression to feeding tubes?
Yeah, I definitely think we need better understanding of gut motility issues in this cohort. I do think progress is being made, and I do think that the research that has been published around this, and full disclosure, this is not an area that we study a whole lot, but it is an area that we're very aware of. The progress that is being made really is pointing us in the direction of small fiber neuropathy driving gut dysmotility. A lot of the biopsy studies have shown that the gut tissue that they biopsy is aganglionic, meaning that in many cases, by the time you have full gastroparesis, meaning your gut isn't moving, if they take tissue, there's no nerve cells in that tissue. So that tells us that small fiber neuropathy is at play. And so that's when we start to think about, okay, well, what can we do to heal that small fiber neuropathy? So I'm really interested in David Systrom's work with the LIFT trial, looking at low-dose naltrexone and pyridostigmine, because these are this combination of drugs which Systrom at least believes is restoring small fibers both to blood vessels and to gut, is potentially something that is really hopeful there in that area. I think with caution, with appropriate caution, because people can have bad reactions, very bad reactions to this. And typically what, the general advice is making sure that your immune system is in a state to tolerate this. But with appropriate caution, there have been publications talking about the use of rituximab, a B-cell therapy, to calm down inflammation enough to allow for small fibers to grow back. If the idea is that neuroinflammation is destroying these small fibers. And then I'm also just, watching the work, and I'm hopeful about the work around FcRn inhibitors, which are a sort of special class of very targeted immunotherapies that can address some autoimmunity that could be causing small fiber neuropathy. And so alongside FcRn inhibitors, I'll also say IVIG, is one of these sort of one of these interventions that I think about with gut motility. But it's such an important problem, but I do think there have been some really good publications in the last 5 or 6 years moving us in this direction.
Brilliant. I could say more on that, but we're going to leap into our last question so we can round up. And it's a question from Sarah. How do we get better support and diagnosis for conditions like MCAS? GPs here, general practitioners, seem ill-prepared for some of the conditions and the sort of comorbidities that COVID is generating.
Yeah, this is a tough one. I am frequently heard saying that we need better MCAS biomarkers, and I have no idea how to deliver on that, frankly. Just because, it's not my real area of specialty, but we find the published literature tells us that 50% of people who respond strongly to antihistamines and mast cell stabilizers have normal histamine levels and MCAS markers. So like there's a whole bunch of allergist journal data to suggest that what we have isn't working. So that's a problem. I also think that we need a lot more research into the role of hormonal health and histamine issues. I think you can be blasting yourself with antihistamines as much as you want, and if your estrogen dominance is out of control or your DAO levels are all over the map, you are still going to have problems with removing histamine from your body and producing too much histamine and all of the other inflammatory problems that mast cells cause. Right now it's just such an understudied area. So I'm really, again, to be encouraging, I'm very encouraged about the fact that we have large funding agencies like the Cohen Foundation who are announcing huge women's health initiatives around hormonal health to dig into these issues, because they are such a cause of cognitive impairment, migraine, daily disability, and in many cases, antihistamines alone or mast cell stabilizers alone without addressing that hormonal component won't get it done. So I know I didn't answer the question there, but
you did. You recognized the difficulty of it and where some of the barriers are and what some of the leads are and some of the difficulties in addressing them. I really get it. And David, I mean, I think we should wrap up there, but I just want to, that kind of leads me to something else. I hadn't expected to feel as emotional as I do at some points during this interview, and I'm just reflecting on that in light of what you just said. It's because you've spoken to us so knowledgeably, open-mindedly, passionately, and kind of intentionally about addressing about understanding and treating these conditions, and you've moved your way across the cobweb, this incredibly complex web of of different symptoms and barriers to understanding and possible lines of inquiry, and I and so many people are just not used to hearing it. We don't hear people weaving the web like this and bringing it all together. And it is moving to hear someone do that in the way that you have. So on behalf of all of, myself, and everyone listening, and many people out here listening, thank you so much for that. And for the way that you're bringing that into your tireless work in clinic and in education as well. And, from all of us, absolutely more power to you. And we want to hear a lot more of what you and others have to say in this direction. And and thanks for being so generous for your time today, but really for your tireless work for everyone with post-acute infectious conditions. Thank you so much, Dave.
No worries. Thank you for having me, and thank you for doing this. This is so important. So I really
my pleasure, and it'll go out on Long COVID Awareness Day today, and it'll be a great way to mark the occasion. Thanks again.
Cool.